Regarding heme synthesis, it occurs in almost all tissues because heme proteins include not only hemoglobin and myoglobin, but also all of the cytochromes which are used in the electron transport chain, cytochrome P450, and cytochrome B5. Heme proteins also include the enzymes catalase, peroxidase, and the soluble guanylate cyclase stimulated by nitric oxide. The pathway producing heme is controlled independently in different tissues. In the liver, the rate-limiting enzyme ALA synthase is regulated by feedback inhibition of the product of the pathway heme. Deficiencies of enzymes in the heme synthesis pathway produce diseases referred to as porphyrias, and almost all of the genetic porphyrias are autosomal dominant. Acute intermittent porphyria is due to a deficiency of the porphyrobilinogen deaminase, also called hydroxymethylbilane or HMB synthase. This deficiency has a late onset and variable expression, with many remaining symptom-free throughout their lives. Signs and symptoms include abdominal pain, anxiety, paranoia, depression, weakness, paralysis, and other motor, sensory, or autonomic neuropathies. Affected individuals excrete ALA and porphyrobilinogen, a heme synthesis pathway intermediate, also called PBG. Both are secreted during active symptomatic episodes. In severe cases, patients can develop a dark, port wine-colored staining to their urine. Acute episodes may be induced by hormonal changes, explaining why this disorder is usually latent before puberty, and by many drugs, including oral contraceptives and barbiturates. If symptoms develop after barbiturate use, this is a clue to the diagnosis. Barbiturates are hydroxylated by their microsomal cytochrome P450 system in the liver, which facilitates its elimination from the body. Barbiturate administration and subsequent stimulation of cytochrome P450 synthesis reduces heme levels. The reduction in heme lessens the repression of ALA synthase, causing more porphyrin precursor synthesis. In porphyrias, the indirect production of more precursors by the barbiturates exacerbates the disease. As mentioned above, deficiencies of other heme pathway enzymes produce porphyrias, in which photosensitivity is a common finding if there is an accumulation of porphyrins, which are formed after hydroxymethylbilane. Characteristic clinical manifestations of porphyrias range from chronic inflammation to overt blistering and shearing in exposed areas of the skin. The most common is porphyria cutanea tarda, which is due to an autosomal dominant deficiency of uroporphyrinogen decarboxylase. This condition begins manifesting in adulthood with largely hepatic involvement. Hepatotoxic substances such as excessive alcohol or iron deposits can exacerbate the disease, and skin lesions are related to high circulating levels of porphyrins. Beta-carotene is often administered to porphyria patients with photosensitivity to reduce the production of reactive oxygen species. The heme synthesis pathway can be influenced by a vitamin B6 deficiency. This is because ALA synthase requires pyridoxine. Deficiencies, which can occur during a malnutrition state or in the setting of isoniazid therapy, may therefore cause sideroblastic anemia with ringed sideroblasts found in the bone marrow of affected individuals. Iron deficiency can produce a microcytic hypochromic anemia. The last enzyme of the pathway, heme synthase, also called ferroketolase, functions to introduce iron into the heme ring, and in a state of insufficiency, there is inadequate heme production. Let's now turn to lead poisoning. Lead inactivates many enzymes, including ALA dehydratase and ferroketolase, and can therefore produce a microcytic sideroblastic anemia with ringed sideroblasts in the bone marrow. Symptoms of lead poisoning include coarse basophilic stippling of erythrocytes, headache, nausea, memory loss, abdominal pain, and diarrhea, altogether called lead colic. Other signs and symptoms of poisoning include the appearance of lead lines in the gums, lead deposits within the abdomen and epiphyses, which can be seen on radiographs. Poisoning can also lead to the development of neuropathy and be associated with elevated urinary ALA levels and increased free erythrocyte protoporphyrin levels. The table on the slide illustrates the comparison of vitamin B6 deficiency, iron deficiency, and lead poisoning anemia. One important distinction among them is that iron deficiency does not cause sideroblastic anemia, since this kind of anemia is due to the accumulation of iron within the mitochondria, which obviously does not happen in deficiency. Let's briefly elaborate on iron transport and storage. The body has no mechanism for excreting iron, so controlling its absorption from enterocytes as well as its utilization is critical. All of the regulation of iron metabolism is at the apical side of the mucosa, where there is a protein called HFE that controls the entrance of iron into the bloodstream. Once in the blood, it is oxidized from the Fe2 plus to Fe3 plus by the enzyme ceruloplasmin to enable Fe3 plus to be transported via transferrin into the bloodstream. To deliver the iron, transferrin binds to its receptor on cells, and once intracellular, the iron is stored bound to the protein ferritin. In hemochromatosis, there is a genetic mutation of the HFE gene that ultimately results in too much iron leaving the mucosa and entering the bloodstream. In this iron overload, ferritin binds too much iron and converts to hemosiderin, from which iron cannot be mobilized. Hemosiderin deposits within multiple tissues cause damage, such as liver cirrhosis and dermatitis. This may also result in a bronze appearance of the skin. Let's turn next to bilirubin metabolism. When erythrocytes are lysed, whether under pathological conditions or via the normal physiological lysis of old erythrocytes in the spleen, the heme released from hemoglobin is converted to bilirubin within the histiocytes. This sequence is depicted on the slide. Bilirubin, not being water-soluble, is transported in the blood attached to serum albumin. Hepatocytes conjugate bilirubin with 2-glucuronic acid from 2 UDP glucuronic acid donors, increasing its water solubility. Conjugated bilirubin is secreted into the bile by active transport. Intestinal bacteria convert conjugated bilirubin into urobilinogen. A portion of the urobilinogen is further converted to bile pigments, called stercobilin, and excreted in the feces, producing their characteristic red-brown color. As such, any biliary ductal obstruction results in the production of pigment-devoid, clay-colored stools. Some of the urobilinogen is reabsorbed out of the intestine and transported in the bloodstream to the kidney in the converted form urobilin for excretion. Urobilin has a characteristically yellow color. Jaundice is a clinical condition which may occur when blood levels of bilirubin exceed normal. Jaundice may be characterized by an increase in unconjugated, also called indirect, bilirubin, an increase in conjugated, also called direct bilirubin, or an increase in both. Accumulation of bilirubin in the brain is toxic, causing a condition called kernicterus, and if untreated, can lead to death. When conjugated bilirubin increases, it may be excreted, giving a deep brown color to the urine. Note that in labs, direct bilirubin is a measurement of conjugated bilirubin. Total bilirubin represents conjugated and unconjugated bilirubin, thus the measurement of unconjugated bilirubin can be inferred by comparing total to direct bilirubin levels. Let's discuss a few conditions associated with increased bilirubin and jaundice. First is hemolytic crisis. With severe hemolysis, more bilirubin is released into the blood than can be transported on albumin and conjugated in the liver. Total bilirubin levels increase and may produce jaundice and even kernicterus. Examples of such conditions include episodic hemolysis in the setting of a G6-PDH deficiency, sickle cell crisis, and Rh disease of the newborn. Hemolytic crises may be confirmed by a lab finding of low hemoglobin and elevated reticulocyte count. Next is UDP glucuronyltransferase deficiency. When bilirubin conjugation is low because of genetic or functional deficiency of the glucuronyltransferase system, unconjugated and total bilirubin levels increase. Examples of conditions which cause such deficiencies include Crigler-Najjar syndromes, which is fatal early in life, Gilbert syndrome, which is benign, and physiologic jaundice of the newborn, especially found in premature infants, in which these enzymes are not yet fully developed. Next, any condition that causes liver damage, such as viral hepatitis or cirrhosis, can increase both direct and indirect bilirubin. Aminotransferase levels in these settings would likely also be elevated, indicating associated hepatocyte cell damage. Lastly, any condition that occludes the bile ducts, such as gallstones in the common bile duct, primary biliary cirrhosis, or pancreatic cancer in the head of the pancreas, prevents conjugated bilirubin from leaving the liver. Conjugated bilirubin increases in the blood and may also appear in the urine. In this setting, an accompanying clinical finding would be an excretion of clay-colored stools, reflecting a hindrance of the passage of bilirubin through the biliary ductal system.